Phyllodes tumor overview. The greater the obstacle, the more glory in overcoming it. These are rare breast tumors that start in the connective tissue of the breast, may be spelled also as phyllodes. Phyllodes tumor are most common in women in their 40s, but women of any age can have them. Women with Li-Fraumeni syndrome, a rare inherited genetic condition, have an increased risk for phyllodes tumor. It is classified as benign, borderline, and malignant tumor. The most common indication of a phyllodes tumor is a breast lump that is easy to feel. These lumps often form in the upper outer quadrant of the breast. This type of tumor is not usually painful. It can become visible as it pushes against the skin of the breast, and it may expand the veins under the skin, causing the area of the breast to appear blue. Phyllodes tumors tend to grow quickly. In a few weeks or months, a tumor can reach at least 2 to 3 centimeters. The average size is around 4 centimeters, but they can be several times larger. Around 20% of phyllodes tumors exceed 10 centimeters in diameter. This type of tumor is not usually painful. It can become visible as it pushes against the skin of the breast, and it may expand the veins under the skin, causing that area of the breast to appear blue. The tumor may cause an ulcer to form on the skin of the breast, but this is rare. The ulcer can form whether the tumor is benign, borderline, or malignant. Phyllodes tumor can form in both breasts, but this is very rare. Imaging. A mammogram, the result will show a roundish mass with well-defined edges. In some cases, rounded lobes may appear within the tumor. An MRI or ultrasound, this image test can provide more detail. An ultrasound, phyllodes tumor present as a hypoechoic, partially indistinct, or partially circumscribed mass with frequent posterior enhancement. A cystic component is more typical in malignant phyllodes tumor. Frequently, phyllodes tumor will show increased vascularity and color or power Doppler. MRI evaluation may be of benefit to evaluate for chest wall invasion in malignant phyllodes tumor. Biopsy. Only a breast biopsy can confirm whether the mass is a phyllodes tumor. A doctor may recommend a core needle biopsy or an excisional biopsy. A core needle biopsy involves the doctor taking a sample through the skin using a hollow needle. This may not provide enough evidence that the mass is a phyllodes tumor. An excisional biopsy involves a surgeon removing the whole tumor for testing. Examining the whole tumor can lead to a more accurate diagnosis. Beyond confirming the type of tumor, a biopsy can help determine whether a tumor is benign, borderline, or malignant. Features of a benign tumor include well-defined edges, cells that do not divide rapidly, connective tissue cells that do not look unusual. No overgrowth of connective tissue cells. Features of malignant tumor include irregular edges, cells that seem to be dividing rapidly, overgrown connective tissue cells with an unusual appearance. Borderline tumors have features of the benign and malignant forms. Malignant tumors, particularly those with lots of connective tissue overgrowth, may spread and grow quickly, possibly spreading beyond the breast. Phyllodes tumors are usually sharply demarcated from the surrounding breast tissue, which is compressed and distorted. Connective tissue compose the bulk of this tumor, which have mixed gelatinous, solid, and cystic areas. Cystic areas represent sites of infarction and necrosis. These gross alterations give the cut tumor surface its classical leaf-like appearance, phyllodes. Stromal activity of the phyllodes are generally greater than fibroadenomas and usually monoclonal. Most malignant phyllodes tumor contain liposarcomatous or rhabdomyosarcomatous elements rather than fibrosarcomatous in origin. Tumor margins may help to identify a malignant tumor, presence or absence of a malignant foci, and number of mitosis. The only way to treat a phyllodes tumor is to remove the growth entirely. This can help prevent additional tumors from forming and prevent the existing tumor from causing complications, whether it is benign or cancerous. Small phyllodes may be excised with a margin of normal appearing breast tissue. Re-excision of the biopsy specimen site with a 1 cm margin of normal appearing breast tissue is indicated when the diagnosis of the phyllodes tumor is done and with a suspicion of malignancy. Large phyllodes tumor may require mastectomy. Axillary dissection is not recommended because axillary lymph node metastases rarely occur. Although axillary lymph adenopathy is common, nodal metastases are the exception. A few different types of surgery are used to treat phyllodes tumor. Size always matters. Lumpectomy. The surgeon removes the tumor, along with at least 1 cm of tissue around it. Removing this extra tissue helps prevent the tumor from coming back. Partial mastectomy. If the tumor is larger, the surgeon will remove the entire part of the breast that contains it. If the tumor is cancerous, your doctor may recommend these treatments. Radiation uses high energy waves to kill cancer cells. Your doctor can use it after surgery to treat a cancerous phyllodes tumor that hasn't spread outside of your breast. Total mastectomy. The surgeon removes the whole breast. You can have breast reconstruction surgery at the same time or after the mastectomy. Chemotherapy uses chemicals to kill cancer cells throughout your body. This treatment is an option if a cancerous tumor has spread to other parts of your body. Although at this stage, radiation therapy and chemotherapy are unlikely to help, with a cancerous Phyllodes tumor, and these tumors do not respond to hormone therapy. If a cancerous Phyllodes tumor recurs, a doctor may recommend a mastectomy, surgery to remove all parts of the breast. They may also recommend radiation therapy, chemotherapy, or both. Although benign Phyllodes tumors may not spread beyond the breast, they need treatment to prevent them from growing larger. Otherwise, the lump can become visible and break through the layers of skin, causing pain and discomfort. How fast do Phyllodes tumors grow? Phyllodes tumors tend to grow quickly. In a few weeks or months, a tumor can reach at least 2 to 3 centimeters. The average size is around 4 cm, but they can be several times larger. Around 20% of Phyllodes tumor exceed 10 cm in diameter. Effect on cancer risk. If a malignant Phyllodes tumor occurs, there is a limited risk of this type of tumor developing beyond the breast. Only 5% of all Phyllodes tumors recur elsewhere in the body, according to Breast Cancer Org. Having a benign Phyllodes tumor does not increase the risk of developing cancer, including breast cancer. Differential Diagnosis. Fibroadenoma. The principal differential diagnosis for benign Phyllodes tumor is fibroadenoma, having a pronounced intracanalicular pattern. Sarcomas. Malignant Phyllodes tumor may be confused with pure sarcomas of the breast. Periductal stromal tumor. The periductal stromal tumor is an entity that histologically overlaps with malignant Phyllodes tumor. The main difference being the absence of leaf-like processes. It is non-circumscribed, consisting of spindle cell proliferation localized around open tubules. Metaplastic carcinoma. Carcinoma is also in the differential diagnosis of malignant Phyllodes tumor, but the immunohistochemical demonstration of epithelial differentiation helps resolve the problem. Outlook. Phyllodes tumors are usually cancerous, but they can sometimes return after treatment. Usually, these tumors can come back within a year or two after you have surgery. Cancerous tumors may come back sooner. After the removal of a Phyllodes tumor, a person may experience pain at the site of the surgery, but further complications are rare. Benign Phyllodes tumors are less likely to recur than malignant ones. The doctor will monitor for recurrence, usually within 1 to 2 years after removal. To catch the tumor if it does return, you'll see your doctor for regular follow-ups. Prognosis. The prognosis of Phyllodes tumor is good, with an 80% 10-year survival. The recurrence risk varies with tumor size and surgical approach. Most Phyllodes tumors behave benignly, with local recurrences occurring in a small proportion of cases. Very rarely, the tumor may metastasize, most commonly in the cases of malignant grade tumors. Malignant Phyllodes tumors carry a poor prognosis. Local recurrence. Local recurrences can occur in all Phyllodes tumor at an overall rate of 21%, with ranges of 10% to 17%, 14% to 25%, and 23 to 30% for benign, borderline malignant, and Phyllodes tumor, respectively. Local recurrences generally develop within 2 to 3 years. Distant metastasis. Distant metastases are almost exclusively a feature of malignant Phyllodes tumor. The lungs 66%, the bones 28%, and the brain 9% are the most common sites of spread. Rarely, metastases can involve the liver and the heart. Research done by Dr. Ray J. Libakin. Please subscribe to my channel and click the notification bell if you want to hear more updates. Life has pounded me down and thrust me around time and time again, but I still love life, just as the earth still loves the rain. Susie Kazim.